Chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease is shortness of breath due to lung destruction, leading to decreased elastic recovery of the lung. The ability to exhale primarily comes from elastic fibers in the lung, passively allowing exhalation. In COPD, this is lost. The result is a decrease in FEV1 and FVC and the increase in total lung capacity (TLC). COPD is not always associated with reactive airway disease such as asthma, although both are obstructive disease. Tobacco smoking leads to almost all COPD. Tobacco destroys elastin fibers. However, if the patient is young and a non-smoker, most likely cause is alpha-1 antitrypsin deficiency. Symptoms of COPD include shortness of breath worsened by exertion, intermittent exacerbations with increased cough, sputum and shortness of breath often brought on by infection. Parallel chest from increased air trapping, muscle wasting, and cachexia. Diagnostic testing includes chest X-ray, vaccination test, increased anterior posterior diameter, air trapping, and flattened diaphragms. Pulmonary function PFT is most accurate test. Decreased FEV1 less than 80% predicted. Decreased FVC forced vessel capacity. Decreased FEV1 by FVC ratio less than 70%. Increased TLC due to increased residual volume. Decreased TLCO emphysema, not chronic bronchitis. Incomplete improvement with albuterol. Little or no worsening with methacholine. Plethysmography increased residual volume. Complete blood counts elevated hematocrit due to chronic hypoxia. EKG right atrial and right ventricular hypertrophy, atrial fibrillation, multifocal atrial tachycardia. Echocardiogram right atrial and right ventricular hypertrophy, pulmonary hypertension. Arterial blood gases, increased pressure of carbon dioxide and hypoxia during acute exacerbations. Possible respiratory acidosis if there is insufficient metabolic compensation and bicarbonate level rises to compensate. In between exacerbation, not all those with COPD will retain CO2. Chest X-ray of COPD. Treatment is as follows. Treatments that improve mortality and delays progression of disease, smoking cessation, influenza and pneumococcal vaccinations. Oxygen FpO2 is less than equal to 55 or saturation less than equal to 88%. Mortality benefit is directly proportional to the number of hours of oxygen is used. Indicated if there are signs of right heart failure, heart disease, left failure, or elevated hematocrit. Pressure of oxygen is less than 60 mm mercury. Oxygen saturation is less than 90%. Use only as much oxygen as is necessary to raise the PO2 above 90% saturation. O2 use PO2 less than 55% per saturation less than equal to 88%. With pulmonary hypertension, high hematocrit or cardiomyopathy, PO2 less than 60 per saturation is less than equal to 98%. Treatments that improve symptoms but do not improve mortality or delay progression of disease. Short-acting beta-agonist, example albuterol. Long-acting beta-agonist, example salmeterol, formoterol, or lodenterol. Never use long-acting beta-agonists alone, always combined with inhaled steroids. Anticholinergic agents, example tiotropium, ipratropium, eclidinium, omeclidinium, and glycopyrrolate. Steroids, pulmonary rehabilitation, roflumilast may decrease frequency of exacerbations. Theophylline, lung volume reduction surgery. Treatment of acute exacerbation of chronic bronchitis. Treatment is similar to the acute exacerbation of asthma. Bronchodilators and corticosteroids are combined with antibiotics. Antibiotics are used because infection is by far the most commonly identified cause. Patients have a broad range of response to inhaled bronchodilators, from no reversibility to full reversibility, defined as greater than 12% and 200 ml increase in FEV1. About 50% have some response. Use roflumilast or theophylline when patient has not responded to short-acting SABA, LABA, LAMAs, and inhaled steroids, and you would like to try something other than a long-term oral steroid. Although 50% have some response, anticholinergic agents only ipratropium for acute exacerbation. Although viruses cause 20 to 50% of episodes, coverage should be provided against as pneumonia, H1N1 influenza, and Moraxella catarrhalis. Macrolides azithromycin, clarithromycin, cephalosporin, ciprofloxacin, ceftazidime, cefaclor, ceftibuten, amoxicillin, clavulanic acid, quinolones, levofloxacin, moxifloxacin, and gemifloxacin. Second-line agent, doxycycline, and TMP-SMZ. Next. Inhaled anticholinergic agents such as ipratropium and tiotropium are helpful in both asthma and COPD. However, they are most effective in COPD. For acute exacerbation of COPD, only ipratropium is used. Treatment that has no benefit in COPD, clomiphene, leukotriene, metapars, example montelukast, inhaled steroid monotherapy, IV aminophylline spirometry for an asymptomatic patient as a screening method, even if there is a significant smoking history. Terbutaline, a beta-2 agonist, not better than albuterol. All medical therapy is insufficient. Refer the patient for transplantation. If you are asked what medication delays progression of COPD, the answer is nothing. AECB treatment is identical to asthma treatment. Acute exacerbation of chronic bronchitis is just with less proven benefit. The idea of eliminating hypoxic drive is not accurate. Dyspneic hypoxic patient with COPD must get oxygen. If asthma is not controlled with albuterol, inhale steroids. COPD not controlled with albuterol, anticholinergic, examine tiotropium, then inhale steroids. Lung volume reduction surgery helps some patients with severe disease and large bullae. Long-acting beta agonist, long-acting LAMA, LABA, LAMA. Long-acting beta agonist is salmeterol, formoterol, arformoterol, indacaterol, vilanterol, orodaterol. LAMAs are tiotropium, ipratropium, omeclidinium, aclidinium, and glycopyrrolate. Sleep apnea. Mild sleep apnea is 5 to 15 episodes per hour, while moderate sleep apnea is 15 to 30 episodes per hour. Severe is greater than 30 episodes per hour. Obstructive sleep apnea, far more common, caused by narrowing or closure of the throat. General sleep apnea caused by change in breathing control and rhythm. Obstructive sleep apnea. Obesity is the most commonly identified cause of obstructive sleep apnea. Patients present with daytime somnolence and history of loud snoring. Other symptoms include headache, daytime sleepiness, impaired memory and judgment, depression, hypertension, erectile dysfunction, and bull neck. Treatment is as follows: weight loss, avoidance of alcohol and sedatives, oral appliances to keep the tongue out of the way, continuous positive airway pressure, CPAP, surgical writing of the airway, uvulopalato-pharyngoplasty if that fails. The increased bicarbonate sleep apnea is obesity, hyperventilation syndrome. Central sleep apnea, CSA symptoms are the same as those of obstructive sleep apnea: daytime sleepiness, insomnia, inattention, erectile dysfunction, and snoring. In central sleep apnea, the respiratory drive is repetitively diminished from stroke, heart failure, or opiates. A unique feature of CSA is lack of abdominal or thoracic movement during pulse pauses in breathing. Treatment is CPAP, polysomnography. Sleep study, most accurate test, will show greater than 5 apnea/hypopnea episodes per hour. There is no daytime hyperventilation. Bronchiectasis. Bronchiectasis is chronic diarrhea of the large bronchi, a permanent anatomic abnormality that can't be reversed or cured. It is less common than it used to be because of treatment for lung infections that cause weakening of the bronchial walls. Single most common cause of bronchiectasis is cystic fibrosis. 50% of cases. Other causes are infections, tuberculosis, pneumonia, abscess, and hypogammaglobulinemia, immune deficiency, foreign body or tumor, hereditary bronchopulmonary aspergillosis, and vascular disease such as rheumatoid arthritis. For the most likely diagnosis, recurrent episodes of very high volume sputum production key to diagnosis, possible hematopoiesis, dyspnea and wheezing in most cases, weight loss, anemia of chronic disease, crackles on lung exam, sloughing is uncommon in dyskinetic cilia syndrome. Diagnosis of bronchiectasis requires an imaging study of the lungs such as a CT scan. Diagnostic technique is as follows: as X-ray vaccination test will show dilated, thickened bronchi, sometimes with the tram tracks, thickening of the bronchi. Hydrogen CT scan, most accurate test. Sputum culture to determine the bacterial etiology of recurrent infections. Figure 4.3 bronchiectasis with widening of the bronchi in multiple areas. Treatment is as follows: chest physiotherapy, cupping and clapping, and postural drainage to dislodge plugged up bronchi essential. Antibiotics rotated 1 week each month. Possible surgical resection of focal lesion. Tornase alpha, an enzyme which cleaves DNA in sputum to reduce viscosity for bronchiectasis rising from cystic fibrosis. Beta agonist and pulmonary rehabilitation are not clearly effective. Treat each episode of bronchiectasis infection as it arises. Use the same antibiotic as for exacerbation of COPD. The only difference is that with the bronchiectasis, inhaled antibiotics have some efficacy and a specific microbiologic diagnosis preferred since Mycobacterium avium intracellular can be found.